I don't want anything that would disrupt. Good evening, distinguished ladies and gentlemen. I think we're about to commence our first in the series of webinars that we'll be hosting this period. And my name is Onwara Moloku, and today I'll be the moderator for the sessions. Today, we'll be discussing the forgotten men, confronting the male infertility crisis in Nigeria. It's important that we recognize that global research has found out that about 50% of infertility cases in most relationships are associated with the male in those relationships. And it's important that we do not forget that that discussion quite often it puts a lot of burden on the other gender. But today, we need to be able to bring the man in focus. But we need to set some ground rules before we go into today's session. First and foremost, all participants and panelists should please mute all their devices while anyone is speaking so that there is no interference from any quarters. For the participants, you would find out that you may not be able to speak unless you are turned into a panelist. But most importantly, I would like you to, if you have any questions as a panelist, please go to the chat box and drop your questions in the chat box. And if you're a speaker, we would expect that you just put up your hand, raise your hand digitally, and we would see you, and then we would then open the floor for you to be able to make your comments, especially when we have the Q&A sessions. Today, we're going to have a very, very robust discussion, and we have very, very erudite speakers who will be doing justice to the program. Today, we have on the roll call Dr. Abayomi Ajayi, who is the CEO of Nordica Fertility Center. He will be setting the stage where he will be talking about why male fertility matters. The major presentation today will be done by three of our very distinguished doctors in the house and one of our psychologists in the house. We're going to have Dr. Victor Ajayi. He will be presenting 2 decades of declining sperm quality in Nigeria, trends, patterns, and implications. This is the result of 2 decades of research from Nordica Fertility Center, where they've been able to observe and keep very stringent research work on the male factor infertility. Then we'll have the second presentation, which will be the silent burden, psychological and emotional impact of male infertility. That will be taken by Mr. Pilot Bolahon. He is a very erudite psychologist. He's our resident psychologist with Nordica Fertility Center. And our third presentation will be taken by Dr. Jesse Atongo, and he will be talking about innovative approaches to diagnosing and managing male infertility in assisted reproductive technology. After those 3 sessions, we'll go into a Q&A, and at that point, we'd like all our participants to please engage properly, ask questions. There is no foolish question. Every question is important. So time permitting, we're going to have about 15 minutes of Q&A, and then we then have a wrap-up to just take away from key takeaway from this session. But please note, so that you don't burden yourselves with trying to write too much, this session is being recorded, and the recordings will be sent to every participant who registered. I need to stress that if you maybe did not register, but maybe you got hold of the link somehow, we are happy to have you on board, but we would have been happier if you had registered so that we can have details of who you are, where you are, and we can then also send you the recording after the session. At this juncture, I would like to call on Dr. Abayami Ajayi, who will set the context of why male fertility matters in Nigeria today. Dr. Abayami, please let's put our hands together. I know we will do it digitally. Would like you to take the floor now. Thank you very much.
Yes, thank you, Honora. Yes, it's really a pleasure to be here today, and especially to be talking about this topic that we rarely talk about, at least the way it should be spoken about. And I'm going to be just giving a summary of why male infertility matters in Nigeria. So good day, everyone, and welcome. Thank you for joining us from across the world for this webinar on the forgotten male. Today, we're putting Nigeria right at the center of our conversation. Because if we want to understand infertility in Africa, we have to start with what is happening to Nigerian men. To start with, the scale of infertility, especially in Africa, is really gone beyond, just like Honora said during his opener, it's gone beyond what we see as a woman's problem. We know that globally, the figure is put at about 1 in 6. And even with that, it's a major health issue. But in Nigeria, the figures seem to be higher. Institutional studies report infertility prevalence to be between 16 and 39% in Nigeria. A study in Lagos put it at 26.8%. But here, there is some shift even in the figures. We can now see that about 60% of about infertility cases nationwide are due to the man. We did a study in our clinic here where we saw that 12% of the men had no sperm cell at all in their ejaculate. And of the samples that we examined, 50% actually, the parameters were below par. Another study in the south, from the southeastern part of Nigeria, found male factor alone to be responsible for 42.4% of couples who are faced with infertility. Now, these figures are disturbing, but what are the implications? This has gone beyond health. The impact of these figures has gone beyond healthcare. It's become a social problem. We know that in Nigeria, childbearing carries special social value, and infertility is tied to marital disharmony, stigma, isolation, and even intimate partner violence. Actually, a study from Port Harcourt showed that as high as about 32% of couples who are faced with infertility also had intimate partner violence involved. Now, but beyond childbearing, male infertility is also a red flag to the overall health of men, because it's been shown that men with poor sperm parameters have higher risk of lower testosterone, higher risk of metabolic diseases, higher risk of cardiovascular problems, and reduced life expectancy. So when a man comes for semen analysis, we're not just talking about having a child. We're talking about his overall health and even longevity. So what are the drivers of this? Because it's only when we understand the drivers that we probably will be able to formulate things that will be able to bring this nip this in the bud so that we don't continue to go south as we are going now? Well, the good thing is that majority of the drivers appear to be preventable. Experts point to sexually transmissible infections, unhealthy lifestyle, environmental exposure, and delayed childbearing. And you will agree with me that many of these factors are preventable. I'm sure a few years ago, the world was shocked when a study showed that as much as 50%, there's been a 50% decline in sperm parameters in developed parts of the world over a period of 50 years. But a similar study done in Africa showed that within 50 years, looking at between 1965 and 2015, the decline in Africa actually is about 73% decline in sperm concentration among African men. This definitely cannot be attributable to genetics alone. This is environment, this is stress, this is lifestyle, all playing together. We know that in Africa, culturally, male infertility is associated with silence, but that silence is costing us too much. This silence has resulted in late presentation. This silence has resulted in women having to carry the burden alone. Why does this webinar matter then? We believe that Nigeria is at a tipping point now. The burden is high and rising. The male factor is becoming the dominant factor in infertility. The consequences go beyond fertility. And like I said, many of the causes are preventable and reversible. We believe that if we get fertility right in Nigeria, we just don't help couples have children. We improve men's health, reduce stigma, and strengthen fertility, strengthen families. So today, let's end the silence. To every clinician, researchers, and advocate here, thank you for being a part of this Nigeria-focused conversation. I will ask you to sit down tight, fasten your seatbelt, and listen to the people who are going to give the presentation. Many of the figures that they're going to be presenting today are local figures. So nobody can say that, oh, these are imported figures. These are figures that we generated right here in Nigeria. So it's very, very important for us to take note of them. Yes, but I must warn that they are also not community-based figures. They are institutional figures, but they point towards something. So I wish you all the best. Sit down. If you want to have popcorn, and then please enjoy yourself. And like Honora said, no question is too simple, no question is too complex. We'll see you at the end of the talk. Thank you so very much.
Thank you very much, Dr. Ajayi. We're very happy to have you on board this evening. At this point, I'd like to call on Dr. Victor Ajayi of Nordica Fertility Center to take his presentation on 2 decades of declining sperm quality in Nigeria, trends, patterns, and implications. Please, let's make welcome Dr. Victor Ajayi.
Thank you, Mr. Honora, and thank you to everyone who has joined us this evening here in Nigeria and from across the world. It's always a pleasure to discuss male infertility, and like Dr. Abayomi Ajayi has said, it's something we seldom talk about, and it's high time that we end the silence. So I'm going to I've christened the topic as a forgotten male or men, the silent crisis of declining sperm quality. So we're going to look at the cultural and scientific neglect of male infertility. We look at what the standard WHO parameters for semen or sperms are, and then what are the global figures. And we also have some figures from our center over the last 2 decades. We look at the causes of declining male infertility or male sperm count. We will not dwell so much on the technical medical part of it. We'll look at what is preventable causes, environmental, lifestyle, and health factors. Then we'll look at implications, public health, societal, and intergenerational consequences. Then we'll look at the possible interventions, and then we'll conclude. For long, especially in this part of the world, in sub-Saharan Africa, Nigeria, we consider infertility as the woman's problem. In fact, when you have a couple, the man and his wife or partner, they've been together for even a few months, 6 months, and there's no pregnancy, the fingers are pointing to the woman. Family and friends, mothers-in-law, the problem is always considered to be the female, and that puts a lot of burden on the woman, stigmatization. And even medically, you see that practitioners focus on the woman, tests and investigations and treatments. In fact, it reminds me of a client that we had who, a doctor was seen elsewhere. He had given her, medications to induce ovulation over six times, 6 cycles, and the man was never investigated. It was later when we invited the man in that we discovered, there was low sperm count. So even medical practitioners are sometimes guilty of this focus on the female gender. So in doing this, some also injustice has been done to the man because he's not involved in the process, in the evaluation, and then he carries the burden also by himself. But we know that in reality, up to 50% of infertility cases are traceable to the man. In fact, there was a study in 2012 which looked at over 4,000 young men. The mean age of the men was 19 years. So young men, only 1 in 4 of the men had optimal semen quality that was adjudged to be okay to be able to get your partner pregnant within the usually 12 months that we talk about. So it's something that needs urgent attention. This was way back in 2012. So it's time to bring men into the conversation, and that is one of the reasons we're doing this webinar. We hope that from this point on, that there will be more talk on men and male factor infertility. Now, what does WHO, World Health Organization, say about the reference values? It's changed over time. 1999 figures are shown there, and up to 2021. There's been some reduction in the baseline figures. However, yes, there's some thinking that, maybe WHO is reducing it because of declining sperm parameters, but this is not entirely so. It's based on research that, these are the minimum figures that are required to, get the woman pregnant within 12 months of regular sexual intercourse. So the figures have dropped. The latest is the 2021 figure, where we say 16 million or more sperms per male is adjudged to be normal. Then there's the progressive motility, should be 30% or more. And then the shape or appearance of the sperms, at least 4% of those sperms should be normal. Okay, so what are the problems that can happen with sperm? So there can be low sperm count, where the number of sperms is lower than what it should be. You could also have a situation where there's what we call teratozospermia, where there's high number of abnormal sperms. There's also what we call astenozospermia, where the movement, the motility of the sperms is impaired or is reduced. Then you can have a combination of all three. There's low sperm count, there's poor or low movements, there's poor or low normal forms, and all three, which we call OATS, oligoasteroteratospermia. You can also have dead sperms, essentially dead sperms in the ejaculate, which is called necrospermia. And then you can have a situation where there are no sperms completely. This is called azoospermia. And then sometimes semen is not produced completely, and that is aspermia. Now, a typical sperm should have one head, which is oval in shape. There's what is called the midpiece, and that's the tail. The head contains the genetic material, the nucleus of the sperm. The midpiece, which is contains the mitochondria, which gives energy to the sperms, and the tail helps movement or swimming of the sperm. So, as the picture shows on the slide, you can have sperms with two heads, large head, double tails. These are abnormal sperms, and this may affect if there's too many of this kind of sperms, more than the 4% that is recommended, you can have situation where the chance of getting the partner pregnant is reduced. Now, there's a worrying trend. The sperm counts have been dropping over the last 5 decades, and the estimate is that it has dropped 50% decline in the sperm count over the last 50 years. And this is worrisome. In those days, we used to see, it's not unusual to see 300, 500 million sperms per ejaculate, total sperms. But to get 39 million now, that is adjudged to be the total concentration that we expect, it's even difficult to get. It's been estimated that there's a decline of 1 to 2% annually every year, and this is a worrying trend. Now, Levine et al. And Levine and his colleagues in 2022 reported this study, the meta-analysis, where they looked at the declining sperm concentration and total sperm count. And you can see the graph is pointing downwards from 1973, downwards. It's pointing downwards where the parameters, the count is declining. The mean sperm count used to be about 100 million, but it dropped to about 49 million, about 50% decline over the about 45 years, 5 decades that was studied. Now, we also did some local studies at Nordica. We looked at sperm parameters in 2003, in 2013, and 2023. And one of the things that we've seen is that this sperm concentration, number of millions of sperms per mil, has dropped from 2003, when we had about 34 million per mil, and then we had about 21 million in 2013. Slightly higher in 2023, but about the same. But the figures had dropped from 20 years ago. Then the motility, the movement of the sperms, also declined between 2003 and presently, and in 2023. Okay. Also, when we look at the semen volume has remained almost the same, but when you look at the grading of the sperms, there's what we call the mean progressive motility. When you look at the sperms generally, how is the movement? So in 2003, the most common one was good motility, progressive motility. But in 2013 and 2023, the commonest that we see is fair motility. This also says the same thing I just said now, where you look at in 2003, good motility accounted for up to 50% of the semen that we analyzed. But look at 2013, good motility had dropped to 15%, and alarmingly, in 2023, it's just 3%. This is something that is also worrisome. Now, we also looked at more recent data from our clients. And, if we look at Q1 of 2025 and Q1 of 2026, and if you look at normal sperm parameters, it's declined, so by about 8% decline in those that had normal semen parameters in 2026 versus 2025 Q1. If you also look at what we call asteroteratospermia, where we talk about reduced movement and also abnormal shape of the sperms. There's been an increase in this abnormality by 15% compared to, 2026 quarter 1 versus 2025 quarter 1. Azoospermia, where there's no sperm at all, has also worsened, in 2026 by about 3%. Okay, so this also supports the fact that parameters are worsening over time. This is also a summary of, the normal sperm. It's a bar chart showing that, if you look at the blue bars there, that's talking about normal sperms. We can see that, it's reduced over time. If you look at quarter 1, 2025, quarter 2, quarter 3, quarter 4, up to quarter 1, 2026. However, azoospermia, no sperms, has gotten worse over the last year. Also abnormal sperm count generally, grouping all of them together, continue to worsen up to quarter 4, 2025. There's a slight decline in quarter 1, 2026. Now, what are the causes? As I mentioned earlier, we will dwell more on what causes are preventable. Our environment has increasingly become toxic. You agree with me that we're exposed to so many industrial, even in our food, plastics and all that, and rising pollution, especially in our cities. And most Nigerian cities now are, the civilization has improved. There are more cars, there are more industries. Okay, so these chemicals from pesticides, plastics, industrial wastes, they can disrupt the normal hormones of the body and, of course, suppress sperm production. Air pollution from vehicles, sometimes these environmental factors are not even visible to us, for us to run away from them. Sometimes they are invisible, they are just in the environment, but they are damaging sperms, they are damaging the DNA of the sperms, which affect sperm quality and indirectly affect male fertility. Okay. Lifestyle is also a major cause for concern. You could call it the modern era, where the trend is to, belong to people who, smoke, peer pressure and all that. So alcohol ingestion, for instance, has been shown to reduce testosterone levels and impair sperm production, and also can damage the DNA of the sperms. Same with tobacco smoking, cigarette smoking, vaping. These are things that are harmful to sperms. Substance abuse, marijuana, cocaine, several of them have also become somewhat a trend. I remember a presentation I had with graduating students in one of the universities, and I was going to talk to them about preserving their fertility. And we at the end, one of them came to me and said, marijuana is like food to me. I take it 3 times a day, And these are young people who are just graduating, So it's a major problem, and it's one of the things that is significantly affecting sperms. Okay, so also obesity, overweight, poor diet, lack of exercise. These are things that have been shown to affect the hormones, that produce sperms, and of course can lead to poor sperm parameters, as we're seeing these days. And a lot of people indulge in sedentary lifestyle these days. Okay. Yes, scrotal overheating, tight pants, laptops on the lap for prolonged periods, long distance driving, people living in cities where there's heavy traffic and they sit, for so long, all this can affect the sperm production. The testicles are in the scrotum outside the body, not by accident, but by specific design, in the sense that the heat inside the body, the sperms actually the testes started forming in the abdomen, but to keep them cool, they are in the scrotum outside the body. So if you heat them up by tight pants, the laptops we spoke about, sitting in prolonged periods, hot baths, saunas and all that, these are things that can damage sperm production. Okay, stress, steroids, bodybuilding steroids, stress, lack of sleep. Testosterone has been shown to peak during deep uninterrupted sleep. So if you don't have enough sleep, this can also affect your fertility. Okay, health factors, sexually transmitted infections, gonorrhea, chlamydia. These are things that can cause damage to, the sperm producing tract or transport tract and even testicles, and this can affect fertility. Unfortunately, most of the time, the gonorrhea and chlamydia will have caused a problem many years ago, and the men we see them when they come for fertility treatment and discover that they have poor sperm parameters. Some don't even remember they've had these conditions while in their younger days. And then there's also the issue of treatment. People, use herbal concoctions, go to quack medical practitioners, and then they get poorly treated, incompletely treated, and then you have, come down with issues affecting their sperms in the long run. Medical conditions like diabetes or, poorly controlled can also affect sperm production. Then there's what we call the sperm DNA fragmentation, which essentially just means damage to the DNA of the sperms. And some of the factors we mentioned already can affect that. So you can find men with normal semen parameters, but because the DNA of the sperm is significantly damaged, then they can have infertility. Alcohol, smoking. One thing I would point out is infrequent ejaculation is one of the things that has been linked to sperm DNA damage, and the other things are shown in the diagram. So sperm DNA fragmentation has been shown to affect fertility outcomes. So IVF outcomes are poorer. Miscarriages are more likely in partners of men who have high DNA damage to their sperms. Okay. We also know that this sperm DNA damage worsens with age, as the graph shows there. Okay, now also, is there what is called andropause? There's a thinking that yes, men also have andropause versus what women have called menopause, though it's not as dramatic as it is in women. It's been suggested that there's a decline in fertility or testosterone levels by 1% every year from the age of 30 years. And some studies, there was one done in 2018 that showed that, partners of when the man is 45 years and older, it takes more than 5 times longer to be able to get his partner pregnant versus if the man was 25 years or younger. Okay, so the age also has become a factor in male infertility. So it's very important that men also make hay while the sun shines. What are the implications? Falling birth rates. Yes, in Nigeria, we might say our population is more than enough, but that family, that man who has not had his own children or child will not agree to that. Children are a premium in Africa, especially in Nigeria also. So we know that is one problem that we may encounter, that people have increasing male infertility. And then of course it will lead to an increased demand in IVF for assisted reproduction, and the cost implications. In this part of the world, in Nigeria, it is pay out of pocket, and so that can be a challenge to do that. Of course, more infrastructure for assisted reproduction will be needed. Hospitals, both private and governmental, will have to be established to manage male infertility. Okay, and then of course the psychological factors also abound. Marital disharmony, mental health, suicidal tendencies in men, especially when you say there are no sperms, azoospermia. These are factors that can, be social or psychological problems. And then, of course, reduced productivity in the workplace when male infertility is a burden to you. Okay. Yes, can this also, be transferred to the next generation? There's that thinking that maybe the sons and grandsons of men with declining sperm quality can inherit the same problems. And then we now, if I may say, sentence the next generation also to male infertility and then to assisted reproduction. So this calls for urgent intervention. So the good news is that, yes, most of these things are preventable. Diet, weight exercise, weight management exercise, avoiding all the harmful, smoking, drinking, use of drugs of abuse or substance of abuse, enough sleep, and all that, can help. And then, of course, safe sex, be mutually faithful to your partner. But if you are not sure, use condoms consistently, and have sexually transmitted infections treated, by the right people. Also, we have to look at it. It's no longer a medical issue, like Dr. Abayomi Ajayi said earlier. We have to, it's become a social issue, and we have to look at educating schools, even from secondary school, I dare say, and then the universities, tertiary institutions should be educated on preserving their fertility, avoiding negative lifestyle factors. Environmental checks by government agencies, pollution and all that. And then we must destigmatize infertility in men and involve them in the discussions regarding men. Even in our consultations, we should, carry them along, which is something we do in our center, where we make sure as much as possible that the couple attend together. So the forgotten emotional dimension, we must counsel them, like I said, we must involve both of them. Men must not suffer in silence. In Africa, we say a man should not be seen crying or should cry in his closet alone, should not be seen crying or complaining. But we need to end that silence. Men should be free to talk about their challenges with infertility, and we should be ready to support them and counsel them. Okay, so I'll conclude by saying that the crisis is real, but the good thing is that we can halt it and begin to reverse it, by putting all hands on deck, clinicians, the policymakers, educators, communities, and men themselves have a big role to play. So together we can remember and rescue the forgotten men. Thank you very much for listening.
Thank you very much, Dr. Victor Ajayi. Thank you for a very, very enlightening presentation. For the benefit of everyone on the program today, it's important that we take note of those things that show that sperm quality is declining over time, and we can imagine what's going to happen. While we think that we have a lot of population, it tells you that maybe in the near future, we may be having a situation where we don't even have enough people, and that may be another challenge on its own. So, but please keep your questions coming. I can see a few questions, 1 or 2 questions already popping up on the chat, but just note your questions so that when we have the question and answer session, we'll be able to deal with as many of them as possible. At this point, I would like to call on Mr. Pilot Bolahan to take us on through his presentation on the silent burden, psychological and emotional impact of male infertility.
All right, thank you very much, Mr. Honora. I would like to start by standing on the established protocols already. And I would like to say very warmly that I'm happy to be here. Honestly, talking about anything that has to do with men and emotional burden is not something that is enough. There will ever be enough time to talk about, but I'm going to try as much as possible to squeeze in as much as possible within the little time that I have to also make an impact, because there's a lot of areas that I'll need to touch. But I'd like to start by talking about some of the areas we will need to cover. I'd like to talk through 6 segments. 1, I'd like to start with giving an opening context. 2, talking about the emotional experience, the mental health impact, relationship and social pressure, the deeper dimension, as well as the resilience and a call for action. So the reality is that within the Nigerian context, talking about this conversation and why does it matter, Dr. Ajayi had laid a very good foundation talking about the statistics. So I'll not be talking so much about the statistics anymore. But many individuals are usually surprised to discover how common infertility is globally. But yet, despite these prevalences, some of these which Dr. Ajayi has mentioned, men are rarely included in conversations about emotional support during fertility treatment. In Nigeria, the expectation to become a father is often deeply embedded within cultural as well as family structures. Men are frequently viewed as carriers of lineage, family names, and inheritance of traditions as well. So consequently, the fertility difficulty for men can challenge not only the reproductive goal, but also the personal identity and as well social status. You know, in the traditional time, if you're a farmer, you'll have a very large family. So we can also use that in trying to understand modern realities. So unfortunately, the societal expectation often discourage men from openly discussing emotional struggles. Men suffer usually in silence while attempting to project strength and at the same time resilience. So the emotional suppression may worsen the psychological outcome, and it's therefore essential that we recognize infertility as both a medical and a psychological issue. So this conversation really does matter because emotional well-being directly influences treatment outcomes, relationship functioning, and overall the quality of life. So in moving on, I'll be talking about understanding male fertility. So before discussing the emotional consequence, it is important to understand that male infertility actually means that many men make mistakes assuming infertility is synonymous with impotence or sexual dysfunction. But in reality, infertility and sexual performances are separate issues. So a man may have normal sexual functioning and still experience fertility difficulty. So numerous biological, genetic, hormonal, and environmental factors can contribute to infertility. In clinical practice, we often encounter men who have blamed themselves unnecessarily due to the misconception about reproductive health. Accurate information can reduce shame and at the same time promote healthier coping strategies. Urbanization, just as Dr. Ajayi mentioned, lifestyle changes, dietary habits, and a lot of environmental exposure emerge as contributing factors to fertility challenges among Nigerian men. So understanding fertility as a medical condition helps challenge the harmful stereotypes. And it is also encouraging to say that the earlier intervention can also help in the global management of it. So moving on to talking about the Nigerian context particularly. Now, fatherhood and masculinity in the Nigerian context, we have to understand that infertility in Nigeria, we must understand the cultural dimension that comes with it, the meaning attached to fatherhood. In so many communities within the Nigerian context, becoming a father represents more than the biological reproduction. It signifies things such as maturity, responsibility, legacy, and social accomplishment. Men often are expected to continue family lineage and fulfilling cultural obligations through childbearing. So as a result, infertility can create a profound sense of personal disappointment and social vulnerabilities, and family members may unintentionally contribute to this distress through constant inquiries about children. You know, we because of the way we are in Africa, sometimes people go to event and they say, "Oh, when will God answer? Oh, God hasn't done it. Oh, okay, don't worry, we'll hear of this good news very soon." Sometimes some of these passive statements sometimes add to the pressure. So imagine a man who have gotten a diagnosis of any of these sperm problems, and then you're asking, "Oh, when will God do it?" You can imagine the emotional burden this person will be carrying. So some men begin to question their worth or their masculinity following some of these diagnoses. So these experiences are like the need for cultural sensitivity as well as sensitive psychological intervention. So healthcare providers must appreciate as well as the general population, the social context in which infertility occurs. So understanding these realities enables compassionate and effective support, as it were. So what are some of the burdens when it comes to the emotional experiences that some of these individuals would naturally experience? We could talk about it, such as disbelief and denial, sadness and grief, profound pain, and the unfortunate part is like the fluctuation over time. So receiving an infertility diagnosis is really a natural experience. Some of these things are things that we clinicians see firsthand. So expressing it sometimes might not really capture the full picture of it, but it is really not a very comfortable experience. Dr. Ajayi has mentioned things such as even suicidal thoughts, and these things are genuinely real. So many men enter fertility investigation assuming that test results will be normal. There's a sense of confidence like, oh, I'm good at my performance, so there's nothing wrong with me, I am fine. But when results indicate fertility challenges, the emotional impact can be very substantial. Men frequently report things such as shock, confusion, and a sense of disbelief. Some initially reject the diagnosis and even go as far as doing confirmatory tests or seeking multiple opinions. Others withdraw emotionally while attempting to process the information privately, and the diagnosis may trigger grief because it represents a loss of an anticipated future experience. So men often mourn the imagined child, future family milestones and personal expectations. And emotional reactions may change over time depending on the treatment outcome and support systems available. So it is important for healthcare providers, as we are doing today, because I've had privileges of sitting down in some sessions, and to the women sometimes is, oh, my husband is not even supporting me enough in this journey. But sometimes the man is also carrying a lot of emotional burden himself. So men, please, it's also very good that you are able to express. So support is one very important thing that you shouldn't take for granted over the course of your fertility journey as well. Now, infertility as an invisible grief. So I mentioned grief earlier, and you may wonder, how do I mean grief? Now, one of the most overlooked aspects of infertility is actually the grief, even not just for men, but also even in women. But we're focusing on men today. So society tends to recognize grief associated with the death, but often it fails to recognize grief associated with fertility. But yet, the emotional pain can be profound. Men may be mourning the possibilities, hope, the future experiences that may never come. And because infertility grief is very much invisible, individuals often receive little validations from others or even support. Friends and family offer unhelpful reassurances rather than acknowledging the actual loss. So this can leave men feeling misunderstood and isolated, and sometimes some attempt to suppress even the grief entirely, and others immerse themselves in work or avoid discussion, some of the things which Dr. Ajayi had mentioned earlier. Psychological intervention can help men process these losses in healthy ways. So supporting or coming into therapy or coming in for counseling in the course of your journey for fertility is a very key fact of your fertility journey. I can't begin to experience or share some of the session experiences firsthand of how some of these things really do play out in men. And one of the ways it does play out in men is that it affects the impact on their self-esteem and identity. So many men derive a sense of identity from the ability to provide, to protect, and eventually to even be a parent. So when fertility difficulty arises, these assumptions may be challenged, and men sometimes describe feeling defective, broken, feeling incomplete. Some even would even feel so bad for even their partners that they feel like, oh, why am I keeping this person? Why do I don't even deserve to even have my wife? And such belief can significantly, create psychological consequences, and reduced self-esteem may affect confidence at work, social engagement, marital interactions. It can even impact social engagement. They may decide not wanting to engage in family or even friendships anymore. And importantly, infertility does not diminish a man's value of character. I need to state that very, very strongly. Your inability to provide or to be able to be fertile or get your wife pregnant does not reduce your value or your character, because with effective psychological intervention, we can help individuals be able to separate reproductive capacity from personal worth, which is very, very important. So the reality is that inability should not connote, or that vulnerability, as it were, should not connote a general sense of weakness, but rather it should continue to promote strength. Now, there's a case here that I would just quickly like to share, just to buttress the reason why I've highlighted self-esteem as a key factor. Now, in this case, we are talking about Mr. Ade. This is just a generic name, who has an infertility issue, is very successive at work, but we can see that this infertility is affecting his overall quality of life. But his story demonstrates how infertility can affect even highly successful individuals. Although he excelled professionally, but infertility undermined the sense of personal competence. Social withdrawal became his primary coping mechanism. We know some people who will just immerse or bury themselves in work because they would say, what am I going home to do? But unfortunately, avoidance often increases emotional distress. And rather than reducing it, his reluctance to discuss emotional problems reflect a border between social expectation regarding masculinity. And many Nigerian men have been taught to suppress vulnerability and maintain emotional control. But over time, this can create marital distance and psychological strain. But through counseling, we're able to help this client learn that emotional separation is not a sign of weakness. He developed earlier coping communication skills and coping mechanism, and this has also impacted positively on his marriage. So what are some of the mental health impacts? This is the third phase of my presentation, and I'll be speaking on depression and men infertility. Now, depression is one of the most common yet least recognized psychological consequences for male infertility. And why is this so? In clinical practice, many men do not present with obvious sadness or with obvious emotional challenges. Instead, they may become irritable, emotionally distant. Oh, my husband is not even communicating with me, or even as bad as it sometimes can even reflect to excessive focus on work or just burying themselves at work or even in their business, depending on the walks of life that they have. And family member may perceive them as, oh, this man is uncaring, when they are actually struggling emotionally. So depression often develops gradually as infertility continues and expectations remain unmet. So repeated treatment failures can further reinforce feeling of hopelessness. And in the context of Nigeria, where fatherhood carries significant cultural importance, these depressive symptoms may be compounded by societal pressure and perceived stigma. So men also avoid seeking mental health support generally because of fear regarding judgment or showing a sign of weakness, because the general assumptions in the world are that you're a man, be a man, you should be able to fix your problem yourself. You don't need to get support from anywhere. So it is therefore important to, screen routinely for depression and depressive symptoms, even in men, because I remember a case where I was speaking with a couple, and the wife was, verbalizing certain things. And when it came to the turn of the man to speak, just to be able to share his own version of it, you would realize that the emotions were so much that he couldn't even share how he felt about things. Another very important thing to highlight is the impact of anxiety. The anxiety can come even in form of the physical symptoms such as sleep difficulty, reduced concentration. It could even come in form of avoidance behavior, not wanting to talk about the conversations or things around the challenges they're going through with their partner. Another form of challenge could be the form of shame, the stigma, and the cultural silence that equally comes with it. The fear of being judged or being ridiculed, or even sometimes the gossips that goes on around within the context of family or the community where they belong or where they live. Now, the sexual function is also a very key part of it. Now, the sexual function then becomes more mechanical than spontaneous. This couples or this man now feels, oh, if I'm going through this treatment, that means within my wife's ovulation. So there's also what we describe as performance anxiety. In the context of it, oh, I must be able to get my wife pregnant. My wife must get pregnant this month. And all of this pressure can then make the relationship look more mechanical than spontaneous. Now, the fourth stage I'll quickly go through is the relationship and social pressure. Now, the impact on the marriage is also very huge, because it can start to develop with the individual, or the man can start to develop things such as withdrawal emotionally. This might also start to affect the relationship dynamics within the couple, the communication pattern, the support. All of these things are things that can equally affect men over the course of the journey with infertility. Now, another very important point to talk about is the family pressure and societal expectations. I've mentioned earlier within the context of my presentation to highlight the repeated inquiries about childbearing. You know, when we talk about some of these statistics, like Dr. Ajayi had mentioned earlier, these people are also like us. We have them as friends, as colleagues, as, you know, even happening to some of us. And, you know, sometimes the fact that you're just asking like, how, madam, what's the update? Is there no news yet? These things can equally impact. And then sometimes it's even some friends or society would even say, okay, how about you trying yourself outside? And then the man knows is the problem. So you can imagine the pressure that equally brings to the man. Another case is this case of Mr. Musa, where the family has encouraged him to marry a second wife, believing that the infertility was his spouse's fault, you know, and navigating through this challenge, you can imagine how this difficulty was, because for him, his coping pattern became avoiding discussions around the diagnosis and the fear of the judgment. But through psychological support, it was also, and couple therapy, he was also able to navigate through these challenges as well. Now, the digital communication is also supporting us now. We're having more awareness, more men are becoming more aware. Men are also becoming more aware that you can, you know, be vulnerable with your emotions, and it's not the end of the world, even while you want to stay strong, because you have to be strong even for the child or the children that you're expecting to bring into the world. So being emotionally vulnerable is also a sign of strength. So what is the deeper dimension into what we've said today? Now, when infertility challenges attacks masculine identity is also one key factor. So how you know, for many men, fertility is unconsciously incorporated into their sense of identity, competence, and masculinity, you know, and this is something that is also very, very important. Emotional reactions such as anger, frustration is also an emotional suppression is also one key factor over the course of this challenging period for men. Now, there's also the workplace performance and professional life impact. You know, sometimes it impacts the, you know, one of the things we say within the clinical context is that infertility can sometimes impact the overall quality of life of the individual. So imagine somebody whose thoughts, his feelings and his emotions are overly overwhelmed by the emotional distress he's experiencing over his journey of infertility. Dr. Ajayi has mentioned as well the financial burden, but I think I do know, if I can mention it here with the permission of the MBD, partnership with Access Bank as well. Sometimes this can equally help in terms of reducing the burden and solely carrying the burden of the fertility journey all by yourself. The role of spirituality is also encouraged, but at the same time, taking full care of your health psychologically. Sometimes some people might feel, am I being punished for all of the things I've done in time past? But the reality is that with psychological help, we could help you put some of those things in perspective. And this, our last case here shows the successful rate of sometimes the impact of couples therapy as well over the course of the journey. So in trying to conclude, we would say that the factors that promote psychological resilience include things such as supportive relationship. It's a journey, both partners have to go through it together, effective communication, adaptive coping, and as much as possible, I would always recommend professional support, because sometimes that helps to ease the burden. Now, I'm going to try and close or round up slowly with this reflection. Now, in this reflection, at this point, I would like to participants to please engage in personal reflection. If you have somebody going through this journey, what would your advice be to the person having listened to these two parts of the presentation and the third part that is coming up? So recommendations are for our men. The realities are that, you know, and family as well as community, you know, seek accurate medical information. For our families, provide emotional support, don't judge, don't ask too much of an offensive question. Rather than asking, sometimes provide support, ask about what the partners need. So for in terms of our key takeaways, as I conclude, it's important to remember that fertility affects far more than the reproductive functioning. It influences emotional health, identity, relationship, and overall well-being. So there's a call to action as well. And I say that let's all not just listen to this presentation today, but also trying to make use of the information that has been duly shared. So in closing, I would say that a man's worth is not measured by his fertility, but by his humanity, character, relationship, values, and contribution to those around him. Thank you very much.
Thank you very much, Pilot. Thank you for that wonderful presentation. The questions have been coming in, so I'd just like to encourage everyone who has sent in a question that please, when the final presentation is done and we go into the question and answers, we will definitely take as many of the questions that you have raised, and they are very, very vital. But please, let's also keep particular reference to Pilot's presentation. The psychological end of things is not just a medical condition. It's got to do with how we all react when we find out that we have some kind of infertility challenge. So please, let's just keep the questions coming and we'll take them. At this juncture, I'd like to call on Dr. Jesse Atongo, who will be taking us on innovative approaches to diagnosing and managing male infertility in assisted reproductive technology. Dr. Atongo.
Right. Good evening, everyone. Good evening, attendees. Thank you very much for taking out this time to spend this evening with us as we share knowledge, as we share, light on the forgotten men, the challenge and the burden of male infertility. Thank you, Nordica Fertility Center and our MD who is here for putting this together to be able to attend to the burden of infertility, male infertility in the society today. So I would like to go through my slides quickly. I'll be discussing innovative approaches to diagnosing and managing male infertility. And of course, these are innovations at the Nordica Fertility Center or across our centers in Lagos, Asaba, and Abuja. So today I'll be going over, I'll skip most of the other discussions that are already being discussed, the definition for infertility, the etiology. Dr. Ajayi gave a good talk on that. So I'll skip some of these slides so that we'll go to the solutions proper, which Nordica offers for combating this burden of male infertility. So just a brief overview. 1 in 4 couples have to deal with infertility. And as we know, there is primary infertility and there is secondary infertility. Primary being that the couple never achieved pregnancy before, while in secondary infertility, they've had a successful pregnancy before, but now having challenges achieving subsequent pregnancy. The male factor often overlooked. In fact, the way society is built now, we tend to quickly blame the woman for it. But from what Dr. Ajayi presented, you come to see that the male factor burden is quite increasing, significantly. We talked about 50% of infertility coming as a result of the male factor burden. So this also is something we should talk about, because if a couple begins to face infertility, with the family members' support relations should not be quick to blame the woman for it. Rather, they should look for a collective way of finding solution, because infertility is actually defined in the concepts of a relationship, a couple relationship. So it's not a one-person definition. It's a definition in a couple sense where a man and a woman is involved to make that definition happen. So the solutions should also be collective. It should not be judgmental. It should be supportive and collective solutions to be able to address whatever the challenges are. And this is also very comforting for me, because the solution that we offer addresses all causes of infertility, whether they are male factor, whether they are female factor, whether they are collective, whether for both or unknown. The solutions are the same, and then the aim is just to achieve fertility for that couple. So a male factor infertility is defined as the inability of the man to successfully impregnate the woman, and most commonly is due to problems of sperm quality, sperm quantity, or of delivery of the sperm. So causes, I'll go over them quickly. Genetic causes, chromosomal abnormalities like the Klinefelter syndrome, where there's impaired spermatogenesis. Then lifestyle and toxins. This is where, one of those indices that is causing the significant rise that we have these days: alcohol, drug abuse, illicit drug among the young people. Many times they don't know the implications of these drugs and the manifestations of these drugs. Heat exposure, occupational toxins, compromising sperm quality. There are real challenges that we have in society today. Then varicocele and, the impact of varicose veins, previous scrotal genital surgeries. The medical conditions like diabetes, hypertension, systemic illnesses also impact significantly on sperm function. STIs, opiitis, epididymitis can obstruct damaged sperm pathways. These are also significant because sometimes as young people, they get to have these infections not properly treated. And then several years later, the impact on fertility, begin to manifest. Of course, idiopathic is also a quite significant part because we've seen young people come into the clinic and there is no visible cause that they could identify. They don't use drugs, they don't take alcohol, they never had surgeries before, they never had this occupational exposure to toxins, but yet there's significant male factor infertility. So that is also a significant cause that we've seen. So in diagnosing male infertility, first is the medical history, where a proper history is taken: sexual history, medical history, surgical history. And of course, in taking the history, childhood history is also very significant. Then lifestyle factors, very significant histories. And many times, as we go through it, you see the impact that it exerts on spermatogenesis and then subsequently male infertility. So after a detailed history, the next thing is to do a detailed general examination. The testes, you want to do a palpation of the testes. You want to palpate the epididymis, the vas difference, look out for signs of varicocele. Then the semen analysis, which is the gold standard for diagnostic tool for the male infertility. So it gets to check the quantitative, and it's a qualitative and a quantitative analysis of the semen of the man, helps to make an objective diagnosis of male infertility. So looking details at the seminal fluid analysis, I had some questions popping in. At Nordica, we do the pre-test instruction, which we call the Nordica protocol, a 2 to 5 days period of sexual abstinence prior to collection. This is also important because if the duration of abstinence is more than 5 days, it also impacts on the results by having the volume higher and then also having the motility reduced. So 2 to 5 days period of abstinence is a strict one. So if in a long time they have sex, we recommend that they have sex and then abstain for 2 days and then come in on the 3rd day for the analysis. Then of course, illicit drugs, marijuana, cocaine, they should not have been on those, should have abstained from that, and then hormonal medications. So we also recommend that after the sample is collected in a sterile container, analysis should be done within 60 minutes of collection. And of course, the sample should be kept at room temperature. All right. So in the analysis is first a macroscopic analysis of the sample where the color, the viscosity, and the volume and liquefactions are also checked. Then there is a microscopic analysis where the count is done, the morphology, the motility, and then the cytology analysis and done and then reported as well. So the WHO reference values for semen analysis, you see that there have been progressions from 1999 to 2010, and then the current one, the 5th edition, which is the 2021. I know somebody sent in the question regarding this. So in the analysis here, you see that there is a concentration. The concentration refers to the count per mil. That's where the normal is 15 million sperms per mil. It's different from the total sperm count, which is the total sperms in the volume. The normal volume now is taken to be 1.4 mils. The total sperm count is the 39 million. So there's a difference between the total sperm count and the concentration. Somebody asked that question earlier. So the progressive motility is now taken to be 30% as the cutoff for normal, while the total motility is 42% as the cutoff for normal. The morphology is still at 4%. So these are the WHO current 2021 reference ranges that we use in our clinic, and it's also used globally. So Dr. Ajayi mentioned this. These are just different parameters, what we call the spermogram, the normal sperm, the oligozospermia, where there's a low sperm count, the cryptozospermia, where the sperm count is less than 100,000, it's 100,000 or less. Then azoospermia, where there is no sperm at all. Then there is teratozospermia, where there's an abnormal morphology. The astenosospermia, where there's abnormal motility. Oligostenosospermia is a combination of all of those abnormalities. And then the necrosospermia, where there's no live sperm, all the sperms are dead in the sample that is produced. So also describing morphology, we use the Kruger's strict criteria for assessing morphology, where every sperm that shows any abnormality in the morphology is counted as abnormal. So that's what is used here at Nordica. It's actually the standard around the world. So the DFI, the DNA fragmentation index, okay, it's also one of those investigations we do here. It helps us to check the DNA integrity of the sperm, because it's another thing to have a normal sperm count, a normal sperm parameters, but the DNA integrity of the sperms, if it's not intact, if there's a large percentage of sperm cells with damaged DNA, that also significantly affects the quality of embryos that are formed, and also the success of those embryos, the genetic success of embryos, how they perform, whether they will implant, whether the pregnancies will be carried to term, depends on the genetic quality of the embryos. We know that for embryos to be formed, 50% genetic material has to come from the sperm, and 50% genetic material has to come from the eggs. So it's one of those tests that is done here at Nordica that helps to further scrutinize the integrity of the sperm samples being used for the fertilization process, and then also helps us to improve our chances of success of the IVF process as it is done. It's recommended that at least it should be less than 15%, the DFI, the DNA fragmentation index. So it should be less than 15% of the sperms to have the damaged DNA. So when it's above 15 to 25, it's good to fair, and when it's 25 to 50, it's fair to poor. What do we do when it's elevated above what we consider as normal? There are lifestyle modifications that we recommend. We recommend that there should be no alcohol taking, there should be no cigarette use, there should be no coffee use. Then we recommend regular sexual intercourse. That helps to improve the genetic quality of the semen as well. We know that semen gets stored in the body, and as the man's body is exposed to heat, to environmental toxins, the damages tend to take place. So when a man gets to have sexual intercourse, stored sperms are expelled, and then that gives your body the opportunity to form new sperms, which are younger, more energetic, and then more likely for better DNA integrity. So that is recommended. Also, vitamin C is also recommended to help improve the DFI. So usually we place the clients with a high DFI index. We place them on these recommendations for about 1 month, and then we repeat it again. We repeat the test again in 1 month time to be sure that the results are better before that sample is used to form embryo. Because for us, we want to have success, not just to do an IVF process, but to have success at the end of the day. So these are the things that we do to make sure that, make clients who come in have a very good chance of having successful embryos, good genetic embryos, and then success with the IVF process. So, like for a general statement now, the management of male fertility, of course, there are medical conditions, hormonal medications that could also be given. If we do a testosterone and we see that if there are subnormal values, those could be given. Then antibiotics for infections, and of course, vitamin C, like I mentioned earlier, which is an antioxidant, helps to lower down the oxidative stress. Now, for cases of azoospermia, we know that azoospermia is a situation where there is no sperm found in the ejaculate. It could be obstructive or non-obstructive. So in a situation where it's an obstructive azoospermia, it means the spermatogenesis is actually taking place in the testes. It's just that the sperms are not able to pass out through the penis when it's ejaculated. So those situations, they could actually benefit from what we call the testicular sperm aspiration. So when they come into an IVF clinic, sperms are taken directly from the testes and then used for the IVF process, and that helps to achieve fertility for that group of individuals who would have azoospermia. So it means there's actually hope for those people. So if you just go into a clinic and they say you have azoospermia, you also need to come, see a specialist who will be able to do this for you. If it's obstructive, there's still hope where we could go to the testes and aspirate those sperms directly from there, and then use that for an IVF process, and then help you achieve your reproductive goals. So other techniques that we get to do here at Nordica is the ICSI. ICSI is intracytoplasmic sperm injection. Of course, for people who have low sperm count, like all those other abnormalities that we mentioned earlier, low sperm count or low motility or low morphology, the ICSI, it's one of those procedures that we do here basically for all our clients. It helps us select the sperms and inject them directly into the egg, as you can see here. So it takes away the burden of the sperms having to swim themselves to get into the eggs, and this improves the fertility rate, fertilization rates, and also improves the chances of having successful fertilization during the IVF process. So above the ICSI, which is the common thing that most people do, at Nordica Fertility Center, we've gone above that level to do what we call the PICSI, the physiological intracytoplasmic sperm injection. Now, what's the major difference? In the ICSI, the sperms are not screened. Any sperm could be picked up and injected directly into the egg. But if that sperm that is picked up is abnormal or have damaged DNA, the whole process is not going to be as successful as it is. So the physiological sperm injection puts those sperms in a dish containing the hyaluronic acid. So the healthy sperms tend to swim towards the hyaluronic acid, and then we are able to select just those sperms that have demonstrated that physiology of being able to swim towards that set point. So it helps us select the best sperms for the process of the ICSI. So this also helps us improve a chance of getting the best embryos, genetic embryos, and also the better chance of success with the embryos that are formed. There's also this procedure called the IMSI, intracytoplasmic morphologically selected sperm injection, also available here at Nordica, where the sperms are subjected to a magnification of 6,000 magnification to be able to screen them for their morphology. So if you do a semen analysis and you're always seeing the morphology being very poor, less than 4%, like we earlier talked about, you will need not just a normal ICSI, like most clinics will do, but an IMSI, where the sperms are first examined individually so that the ones with the best shapes are the ones that are being used for the ICSI process. All of this is to make sure that we are involving the best sperm in the pool for the IVF process, not just any sperm at all in the pool, because that is significant in ensuring that we have the best embryos and have the best chance of success at the end of the IVF process. Here is also another technique, the microfluidic sperm sorting. Somebody asked if the DFI is high, what do we do about it? First, we'll do those modifications for 1 month and repeat it to make sure we have lower values, preferably less than 50% DFI. And in a situation where it's still that high, we have the microfluidic sperm sorting, which is a special technique that helps us select the best sperm. So this technique helps to mimic, the natural tubular, genital tubular structures that are found in the normal genitalia of the woman, through which the sperms have to swim before they get to the egg. So the sperms are made to swim in this device, and then the fastest swimming sperm cells are identified and then picked up and used for the ICSI process. So this helps us get the best sperms in the pool, and also the sperms with the best DNA integrity are the ones that are likely to be ahead of the swimming process. And then those sperms are isolated and identified. And this is what is also available here at Nordica. And then is the reasons why we have good success with our treatment processes. Now, general statements on prevention. This already been talked about. Avoid illicit substances, healthy lifestyle, avoid excessive heat, avoid alcohol, practice safe sex to prevent STIs, get sun exposure, because that's where you get the vitamin D from. All right, so in conclusion, May factor contributes significantly. This 30% is not what Dr. Ajayi presented. We have 50% now. So the burden for male factor infertility is increasing every day. You need to create awareness, and that's why we're having this webinar today, and also to make people know that the solutions are available. There are many advancements that we have now available in the country here, right here in our centers at Nordica, to make sure that men who have this burden, dealing with this burden, can actually get, to achieve their ambitions, so to say, of having children of their own. Now, in conclusion, I have this statement here I want to read out. The convergence of advanced diagnostic and innovative artificial reproductive techniques have brought hopes to countless men who once believed genetic parenthood was out of reach. With the right tool, compassionate care, and personalized approach, we can make that hope a reality. It is now possible for couples to achieve conception with very poor sperm parameters. This has brought hope to many men on their journey to becoming genetic fathers. So this is what Nordica has done through the advancements that we have here available to tackle this burden of male infertility. Thank you very much for your listening and your time with us today.
Thank you very much, Dr. Atongo. That was a very, very beautiful presentation. And I believe that while you were speaking, if you check the question and answer sessions, you would have been seeing that quite a number of people have been asking questions. At this point, I would like us to, we're going to go into some, I want to call it the question and answer session. It would have been nice if we were in a physical location, we would have had the opportunity of a panel discussion, having taken these 3 presentations, but we don't have that luxury with this platform. I would like to start with some of the very exciting questions that we had. First and foremost, for everyone who has been asking when will the presentations be sent, I believe immediately after this presentation, after this event, the system will transcribe all the presentations. And since you sent us your email addresses in your registration, please check your emails from tomorrow, I believe, or Monday, and you would have those dropped on your email addresses that you provided. Dr. Atongo has taken one of the critical questions. Kene had asked this question: what's the normal range for sperm count? Is it 15 million set by WHO or 39 million? So in your presentation, you had carefully highlighted that it's a different, those two parameters are exclusive. So you have to meet both parameters. One is 15 million, the other is 39 million. In the presentation, I don't know who will take this particular question, but I think it's Dr. Victor Ajayi. Can retrograde ejaculation be treated? Can retrograde ejaculation be treated?
Thank you.
Yeah. Doctor.
So yes, an interesting question. For those who may not know, retrograde ejaculation means that, the semen that the man ejaculates, instead of coming out, through the penis down into the partner, is going backwards into the bladder. That's not normal. And that can be caused by some conditions. Diabetes is one of them, poorly controlled diabetes. Surgeries around what we call the neck of the bladder, prostate surgeries and all that. So it depends on the cause. If you are able to control, for instance, with diabetes, controlling the diabetes, there are some medications that can, tighten the bladder neck and allow the sperms to go, because there's a valve there. There's a valve there that controls this, to channel the sperms or semen where outwardly where it should go to. So it depends on the cause. But if it's associated with infertility, sometimes you might need to do IVF because the sperms are not coming out into your partner to get her pregnant. So, and if it's going into the urine, we can do IVF and collect the sperms from the urine. There's a protocol we use to, the urine is acidic, so it will kill off the sperms that enter there. So there's a protocol we use to limit that problem and then collect sperms from the urine and still be able to use it in some cases for IVF, and then the couple can conceive, And there are other options to help such couples who want to conceive. So one way or the other, it can, such situations can be helped.
All right. Thank you very much, Dr. Ajayi. We have another question that says, can fragmentation be solved? If so, how? And this particular participant is over 50. Can fragmentation be solved? If so, how? The participant is over 50 years old, male.
Okay. DNA fragmentation, that damage to the DNA of the sperms. We don't 100% know what causes it, but during the presentation, myself and Dr. Atongo, we've mentioned some of the factors that have been linked to it. So age is one of them. Lifestyle, alcohol, smoking, infrequent ejaculation, and all that. So whichever one is applicable, adjusting lifestyle, for instance, can go a long way in improving that damage to the sperm DNA. Increasing the frequency of ejaculation is also important. There are some medications or some what we call antioxidants, because what happens to the sperm, what causes DNA damage, is called oxidative stress. So there are some things. The simple vitamin C is an antioxidant. There are a lot of them you also get from healthy fruits and vegetables, omega-3 and all those things. So they can help. So if you adjust lifestyle, your diet, if you're overweight or obese, you shed some weight, you exercise moderately, you cut down coffee if you're a heavy coffee taker. These are things that may help, to counter the DNA damage. In cases where, we are not succeeding with this and you have to get the person pregnant, your partner pregnant, sometimes you have to come for IVF. And then we have some techniques we use to select the best sperms in such cases. Dr. Atongo mentioned PICSI. Is a method we use when there's high DNA damage. There's also one we call microfluidic sperm sorting. These are techniques we use to select the best sperms, in situations where the DNA fragmentation is significantly high.
So that I think has taken care of that very important question. I would like this question to go to Dr. Atongo. It says, how does infertility relate with age in marriage, especially with men above 40 years? What can be done?
Okay, infertility and the age of the man. Okay,
Yeah,
like
exactly.
yes, like Dr. Ajay mentioned, there is that relationship, the relationship of age with DFI, DNA damage in the sperm is there. So usually for men who are above 45, PICSI is recommended, and then microfluidics when there is demonstration that the significant DNA damage is there. So from above 45, there could be that impact of age on the sperm quality of the sperm, both the DNA integrity of the sperm and also the parameters of the sperm. So when there is a challenge, the fertility challenge at above 45, as relating to age, then we have techniques here at Nordica that helps to solve that, and those have already been mentioned, the PICSI, the microfluidics that have already been mentioned. Because usually you can't do anything about the age. So if there's an effect, an impact of age on the fertility, then we're just there to help solve that fertility issue with the techniques that we have available here.
All right. Yeah, thank you very much. I think the general thing is over 40, please visit a very good fertility clinic and like Nordica, and you will have the right thing done. And then we're believing that things will be sorted out, professionally. This question will be, someone has made a comment here that talks about the fact that the process for semen collection details quite a number of men, especially for some religious reasons. Is there some method that may be more agreeable to a lot more men? Is there something that can be done?
Masturbation is a preferred method of sperm collection. I understand that for some religious reasons, some people are not comfortable with that, but is the preferred. Yeah, yes, is the preferred. Now there are other methods as well. Washed condoms, that method is also available. Then the withdrawal methods, they are also available when there are very strict reasons why a particular client cannot do masturbation. You have other ways like could be used to also help the client achieve their sample production for semen analysis. Okay. But masturbation is still the preferred method.
Okay, Mr. Pilot Bolahon, this next question is for you. Yes.
Sorry, just to add, because there's a part of the question that says the lab environment is also not conducive. Yeah, so again, if you live near the clinic, you can produce from your house because the samples, we usually need the sample within 30 minutes to 60 minutes. Some people also get a hotel nearby, near the clinic or the lab to produce. Because yes, truly the environment sometimes in the clinic or laboratory may not be very conducive and may kind of even affect your ability to produce. So these are some of the options also.
All right. All right. Thank you very much, Dr. Ajay. This question is for you, Pilot. It says, how can we encourage increased emotional support for men going through infertility?
Okay. All right. Thank you very much, sir. So one of the very important things that we've done today is to sort of like demystify some of these concepts. And the reality is that for men, we need to be able to normalize a lot of these things that we've spoken about today. Because we know naturally women who are very sensitive to their health, they will go all out. But for men, there's a general assumption because of the stereotypical assumptions in men that everything is fine. I'm okay. There's nothing wrong with me. I don't need to talk to anybody. But the reality is that we need to be able to normalize being vulnerable for men, because men have to also be able to express this emotion. So it's not out of place if you know, as a man, you walk into a room and you need to share your burden or share the burden, as I sometimes say to people. So we need to normalize this feeling as to for men to be able to talk. We also very strongly need to routinely include this whole process, some of the things we've spoken about today, especially from the psychological perspective, into the provision of these services. Let men, when they come, also be able to say, okay, I need to, how has it been? You know, you've been married for 5 years, you've been married for 10 years. How has the journey been for you? So expressing sometimes, sometimes in the medical sense, you can take samples, but for us as clinicians, our samples are usually more within the what we can see and what we can hear. So usually when they come in and they're able to express, you can then start to deduce that, oh, this feeling or this thing they are saying seemingly looks more like you're going through a whole lot. So how about we start an intervention for you? That's also very, very important. So being vulnerable and also routinely putting it into the treatment process, I feel is one of the best ways. And I think very importantly, like we generally say, as cousins, as friends, if you have friends or individual going through this, encourage them to speak to people. Sometimes the advice you might think you are giving, if it's not given from a professional perspective, might not necessarily be the best advice. So going through treatment is very, very important. Thank you.
Was key thing is please speak up. Don't keep things in your mind. And I know we're very religious people, but I always advise people that talk to a professional. It's good to be religious. Spirituality is important, but when you talk to a professional, you are likely going to have unbiased counsel. And I think that's very important for all of us men here. There's a very exciting question. Well, it's a comment. I would want to call it a comment. Says there was a time my wife was using medication for endometriosis, and I abstained for a very long time, which has resulted to me not having sex any longer. I've tried Viagra, but it is not working. He also tried IVF once and still waiting. And they've been waiting for about 18 years, not even 15, 18 years. Dr. Ajayi, is there something you can advise to this couple?
Yes, I can relate to his story. Endometriosis is a condition that sometimes also causes painful sexual intercourse. So he shouldn't take it on his wife too much. Because of endometriosis, sometimes there's painful sexual intercourse. So there's that aversion to sex sometimes. Now, to have withdrawn, it's very important to know why you've stayed away. Is it because she can't have sex because of the pain, or you mentioned she was on medications, or because the pregnancy is not happening? We always preach that sex is not only for conception, it's also for companionship, and endometriosis can be mentally challenging, psychologically challenging. So where it is possible to have intercourse, please support her, have intercourse with her. Both of you would, that bonding will help while you're waiting to conceive. The other part of it is waiting for 18 years. I wouldn't know why, but that is not the best thing to do. Endometriosis in particular is a progressive condition. Continually gets worse. And it's known that about 50% of women with endometriosis will have infertility. So the earlier, the better. You do something about it. So I don't know if you have seen a fertility expert. You should have seen one like yesterday or years ago, so that both of you will be evaluated. And then sometimes the best option for endometriosis sometimes might be IVF. So I think you should see one already. See a fertility expert, and then you might want to also speak to a sex therapist, or a psychologist and all that to help this fact that you've not had intercourse. Because if Viagra is not working for you, it's not likely to be a Viagra thing, a drug thing. There might be some psychological thing associated with that.
All right. That I think for this particular participant is also over 50. So there's a time, it's like saying time is ticking, the clock is ticking. So I would encourage you, sir, to visit any of our centers and let's see what can happen. At least with your wife, some kind of assessment needs to be done, and then we take it up from there. It's important to note that infertility is not a religious problem. It's a medical condition. If you have headache, if you go to a doctor, they will give you something, the headache would go. If you have malaria or typhoid, you go to the hospital. Even if we advise you you can pray, but it will be better you come out of our shells and therefore be able to access, medical and scientific solutions to these problems. That's just a general comment from the floor. So very exciting question, which quite a number of men seem to fall into that trap. He says, are there culturally unfriendly sperm boosters, apart from the synthetic ones, in the management of low sperm count? Are there? Dr. Ajayi, I can see you laughing.
Yeah, because this sperm booster question always comes.
Always comes.
Therefore, yes. Well, sperm boosters, neither here nor there. There's no evidence, 100% evidence that sperm boosters help to improve sperm parameters or sperm counts. And the sad thing is that some people depend on it for years, spend a lot of money. Some of them can be expensive. You mentioned the cultural ones, but the synthetic ones, a lot of them can be expensive. And then sometimes you see no results. I remember a client who had 4 million sperms per mil. It's low, and we could do IVF with that. But he went to take some injections. This was many years ago. He was spending about 30,000 naira every month for this injection. By the time he came back, the count was 0. We had to start talking about that thing. So sometimes sperm boosters worsen the problem. Yes, sometimes there are improvements, minimal improvements, sometimes no change, sometimes they worsen the problem. And the woman will keep getting older while you insist on boosting the sperms. And then we know that chances of pregnancy, whether naturally or IVF wise, reduces as the woman gets older. So we don't really push for sperm boosters because they are not evidence-based to be effective. But there are certain things which some studies, also still inconclusive, say may help. But the good thing is that a lot of them are found in healthy fruits and vegetables. Your folic acid, your zinc, L-carnitine, omega-3, so a lot of them are found in healthy fruits and vegetables, which is what we encourage. And then your lifestyle can be, good lifestyle can be a booster of sperms or reversing bad lifestyle. So if you drink, if you smoke, substance abuse, if you're obese and you're overweight, you're not watching your weight, all those things, if you improve on those things, they are more likely to help than the so-called sperm boosters.
So that settles that for me. Now, there was a comment while you were presenting, someone highlighted a comment. It says, infrequent ejaculation causes DNA fragmentation. It says, for faithful partners who are living very far apart, what is the way out?
Okay, yes. So frequent ejaculation is recommended. If I may digress a bit, even when they talk about prostate cancer and all that, frequent ejaculation has been linked to reducing the risk. Okay, so as we just said, for sperm DNA damage, the more you flush out the sperms, the better, because all sperms stay too long, they die, they release toxic chemicals, that causes DNA damage. So yes, sometimes it's not feasible, yes, because we are not together. Masturbation is an option, but again, I know that is not, not everybody wants to masturbate, either for moral, religious, or personal reasons. Okay, so we're not saying automatically if you are not ejaculating frequently, then you have bad sperms. Okay, it's not an automatic thing. So, but where it is possible, where you live together, because someone also asked, I don't know that is the same question, what of people who are single, who are virgins, who are not sexually active, what happens? So we're not preaching that go and have intercourse just to reduce your DFI, your DNA fragmentation. Where possible, this is what is recommended, okay? But if it's not possible, it also does not mean automatically your sperms will be bad.
All right, thank you very much. I think there's a question on cost of ICSI. I don't know, you are in the medical side of things. Nobody is here from finance, but I would advise that whoever sent in that question, kindly look. I'm sure we posted on the chat box all the contact details for all the Nordica fertility centers, Lagos, Asaba, and Abuja. Please go to the chat box, take the phone number, email, and please send that question to any of those phone numbers or emails on the platform. You will get a response. If it's working days, within 12 hours, you would get a response regarding the cost of ICSI. The people here are doctors. They don't deal with pricing issues at the center. Another one is ICSI inclusive in our IVF cycle. Let's refer people to our website for pricing. So that's why I said, please either go to the website, www.nordicalagos.org, and you would find all the issues of pricing. And also you can call any of the centers directly, and somebody will speak to you on the cost, please. Thank you again for posting the phone numbers of all the centers. Ikoyi is 0702-627-7855 or 0807-771-6409 for Nordica Ikoyi Lagos. Nordica Abuja is 0702-627-7855 or 0815-619-6927. Or as I said, visit our website, www.nordicalagos.org, and you would get answers from those platforms. I think it has been a very exciting evening, and thank you everyone who has been here with us. I believe this session has been enlightening, and for me, I think from the kind of questions we've got, it tells you that men are beginning to be interested in finding lasting solutions to some of these problems that some of us may be facing. Thank you, Nordica Fertility Center, for putting this program together. I thank the Chief Executive, Dr. Abayomi Ajayi, for always finding, is a person who loves to share knowledge, share information. That's one of the strong points for Nordica. Dr. Victor Ajayi, I want to thank you very specially for taking out time. It's been a hard Saturday from morning to you're still here with us. Dr. Atongo, thank you for holding forth in Abuja. We believe that this should bring a lot more men to the realization that rather than keeping quiet and dying in silence, let's speak up, let's go and seek help quickly. Just like the women, the age is ticking. A lot of things that we could have solved 10 years ago, we didn't solve them 10 years ago. Well, the next best time is now. Let's not hesitate to seek medical help urgently. Pilot Belahon, thank you very much. It's always a pleasure when you talk to us about managing the psychological side of things. It's, in fact, more depressing if we want to tell ourselves the truth, that infertility, beyond the medical condition, we've seen homes crack up because of it. We've seen deviant behavior, drug use. We've seen all sorts. And, when you see a man, some men have lost it totally, And when people find out what's the deep-seated reason for all the things that have gone through in their lives, it's simply that they cannot tell anyone, that because society doesn't encourage you to speak. They tell us to be men. Man up, my brother, man up. And in manning up, you go and you cause more trouble for yourself. So thank you, Bolan, for always being here for us. For everyone, the technical team, I thank everyone for being here today. Sorry, Nigeria is not there, but next time we'll be there. Thank you. Good evening. Good night.
Good evening. Good night, everyone. Thank you.
Good night, everyone.